Okay. Well, what an exciting time, right? Tons of money for research, apparently. So let's, but also maybe not an exciting time, and we're going to talk about that too. Okay. So let's start on a high note. Following our great panelist that we just saw, let's talk about the landscape of women's health research right now. What are some of the more promising examples we have right now of research that is being done on women's health? And I should pick one of you. Well, we'll start with, because ARPA-H just made a giant announcement last month about $110 million in funding for women's health. Why don't we start with you?
Sure, yeah, and I want to say we actually funded $113 million as of last week. So we're really excited to announce actually one of our awardees is USC. They just got funded last week in our topic 4, which was the lymphatic and brain topic. And that is really actually a great way to talk about a unique innovation that's going to combine a novel drug target in the brain as well as focus ultrasound to get into the right place at the right time in the brain, to be able to really remove debris from the brain to help slow the onset of Alzheimer's for women. So it's going to be a really unique opportunity to combine some innovations that have been in the field for a while to be able to kind of combat a disease that is disproportionately affected by women. So that's just one example. But I have to say we were really lucky in the sense that we really diversified our portfolio of awards to include a multitude of awards in terms of later stage R&D efforts that we can have 24 months to be able to actually get these out into the market, to be able to make it successful, to have actually people use. And then we have these ideas, the Spark ideas, our awards, there's about 18 of them, to be able to spark an idea in women's health, to be able to really push the envelope in what you could see in innovation, to be able to kind of take it to the next level to support women across all ages and stages of life. So that's some really exciting and unique innovations that we've been investing in. I did want to highlight one Launchpad awardee that is in my portfolio in the wildcard topic, and that is something, it's actually a diagnostic for endometriosis. So we know endometriosis, it takes 10 years to diagnose. And this company we invested in already have a proof of concept to look at how can we reduce that time to diagnose from 10 years to 3 days, and also be able to make it from going from an invasive diagnosis to a non-invasive diagnosis. So really trying to speed up not only the innovation, but speed up a way to be able to get the right answer to a woman so they can get the right treatment quicker and faster.
Yeah, it's interesting. I feel like endometriosis is in the last several years taken or gotten a lot more publicity than it ever has, which is really interesting. Another area of women's health that I see getting more research, or at least more interest, is menopause. I don't know if you maybe want to talk about menopause research. Yeah.
I think menopause is, it's been so interesting to see because, people were making in the investment community and in their research space, it was almost a joke, truly, even just 5 or 6 years ago. Because one person said, well, what are you looking for a solution, those little fans? And so that issue of really bringing this to the forefront of what the cost is to us personally, but the economy and overall, and what those solutions are. And there's been so much research going into the space and great companies, technologies that are on the forefront that are really just looking for the fuel to be able to get them into the market.
I think the other piece is that women are demanding more. It's not as much of a breakthrough as such as a culture shift for people to be open and talking about the things that are affecting the way that they live their lives, and really demanding more from their providers and from the institutions that are supposed to be helping them to live better lives. And so I think that's a huge push on that end. I think other piece is people being more open to talking about their family history and being more aware of that genetics is not necessarily a through line for every condition, but it may be an important way to identify whether or not a person might be at risk for certain, and it's not as hidden as it perhaps used to be in the past.
Mm-hmm. And to your point, there's also been a lot more conversation around research for reproductive health, and that runs the gambit, both from sort of fertility, which Tammy can speak to, but also, even looking at sort of, I don't know the full the full lifespan of reproductive health, and we have so much more data at our fingertips, as Anna can probably speak to.
I mean, thank you. I'll just sort of, one important element of this is really, I think, the culture shift that you recognize, and the ability and the freedom for women to speak out about their needs and where there are gaps in both research and in the healthcare system broadly. And one of the most important consequences of that, and the most exciting consequences that I see, is really at work. So we offer a benefit at work from preconception through menopause and midlife. And I'll tell you, I had fertility treatments at this point almost 10 years ago, and I was diagnosed with early onset menopause, and my fertility treatments would yield fewer eggs, blah, blah, blah. But at the time, it was inconceivable that menopause would be something that you could even talk about at work. We were still getting used to talking about IVF and pregnancy. And I think, when we launched our menopause product almost two and a half years ago, it was an open question as to whether, the workplace cared about older women at work in their 40s and in their 50s. It actually became our fastest growing product of all time. So we're very, very excited that I think the cultural stigma and the work that continues, and there's a lot more work to do, but that has really accelerated a lot of investment, I think, in the research space, but also investments in the healthcare system and among employers and health plans as well.
And I think it's important that people recognize that women are more likely to enroll in a clinical trial when they see how they're connected dots between a gap in a medical condition or a concern that's affecting them, the ability to enroll people in clinical trials, and the pace at which all that happens.
Yes. I do want to go back to you, Anna, just because I think another component that we don't talk about, which is sort of interesting, is the tech landscape, and how we sort of have more ability to track data about women's health than we've ever had before. And I hope you could talk about that a little bit.
Yeah, I have a really interesting take on tracking data. My background is in social science research, so I understand the value of data. And I think there was a really interesting conversation had at the lunch plenary around consumer data and being able to utilize some of these tracking features. However, in the topic of reproductive health in particular, especially as we look to 2025, I think consumer health data, I'll be specific, data that's not covered by HIPAA, is something we need to be very mindful about collecting. I think we should err on the side of as little data as possible, despite what help it might be in some ways. I think we have to start thinking about the unintended consequences or risk that we put people at when we collect their menstruation data, in particular, because that is going to give indication of other health experiences like abortion, and that is already a very problematic and very regular health experience for many people in this country, and it's only going to become increasingly politicized, stigmatized, prosecuted. So I think, yes, Data is very beneficial. However, we really need to be thoughtful about the way that we collect it.
Yes, and well, and two things there. One is that prior to, well, in recent years, the FTC has taken it upon themselves to sort of protect or take more action in protecting healthcare that falls outside of HIPAA, which has been a really interesting development. How that will go forward, we don't know yet. But the other thing that I think is interesting about this ability to collect data, whether or not we're using it in sort of a grander way or in a scaled way for an individual company to make use of, there's also the opportunity for patients themselves to make use of it in a way that they couldn't before. I want to shift gears to talk about access. So this is a little bit dated, this information, but there was a 2020 report from the WHO, the World Health Organization, that called progress on women's health in the last 25 years, quote unquote, uneven. And I was wondering if you could speak to that. We're sort of in this interesting age of, incredible access to technology, new direct-to-consumer products, new employer benefits, right? We're thinking about things in a different way. And yet, access seems spotty. I don't know who wants to go first.
Well, I think depending on how you define access, there are a couple of things that come to mind. If it's a product or a drug that requires insurance coverage,
right,
then clearly there are variations there. There are a number of hurdles that people may need to go through if it's something that is not definitely proved to be what's superior to what's already in the market. And the out-of-pocket cost may be insurmountable for some people. So that is clearly a challenge. It may also be a challenge. We know that it takes years for information to move from study result, aha moment, grand discovery, to actual implementation and dissemination. And at ACOG, we really rely on our processes for vetting information and making sure that it's solidly reliable and combining it with existing information in order to formulate clinical guidance. We also have processes to evaluate things that are newly and emergent, but even beyond that, it takes years, and we really need to shorten that timeline.
I think on the access question, we work in the fertility space and in IVF in particular, and one of the things that I'm most excited about over the past 5 years or so is really how access has been expanded through work. More than half of all Americans, 150 plus Americans, and many people around the world who are employed by large multinational American companies get their healthcare benefits through work. And IVF and many other aspects of fertility treatments and women's health have sat outside of the healthcare system for a long time. And what that meant was that women would have to take out loans, they would have to pay for their own treatments, in many cases through savings. Obviously, there's unevenness there and there's financial inequity. And so for us, the ability to see a wave of innovation to unlock employer-sponsored care, employer-sponsored access, where employers contribute financially to the payments for better maternity care, more IVF care, more fertility preservation care for men and women, it has been, I think, a really important moment, and I think we're very much at the dawn of that time, and I'm excited for, I think, what is an expansion motion in the next few years.
It didn't necessarily happen organically, though, right? There was a lot of advocacy that had to take place to make sure that that was available, and I think
absolutely.
Yeah. Oh, do you want to jump in?
I wanted to jump in. I guess it may be a little different, but as how we at ARPA-H think about accessibility, we've actually built it into what we call our Heilemeyer questions. It's how we build out our programs to address a really hard problem. So our director, Renee, had, when she came into the agency, there are 8 Heilemeyer questions, and it's just, they're actually from DARPA. And she added 2 more, and one was on affordability and accessibility. So in every single program that comes out of our agency, we actually make the program managers identify what that is in their program. And for the Sprint for Women's Health, we actually put it to the proposers. So every proposer that made it to our pitch phase, we made them answer all of our 10 highly marked questions, and one of them was the accessibility question. And that was to help us to make a better informed decision, to make sure that people who are building those innovations are actually thinking about that, even if it's a concept, or if it's that later stage idea. How can we bring accessibility and affordability into the innovations that we are going to be funding at ARPA-H?
Can I also add that I think it's really important to think about new ways to expand access that's not through the healthcare system. My focus has always been in abortion. That has always been isolated in many ways, financially, physically, from other reproductive health care, and now legally. And I think there's a lot of conversation around like the innovation of medicines and technologies here, and I think in a lot of contexts it's really appropriate. But there's a lot of sound evidence around the medications that people can use for abortion, and there's no question, or I guess like in some contexts people question this, but there is no question in science of their effectiveness and safety. And so to me, when I think about innovation, I think about access, I think that's the place where there needs to be a lot of attention. There are lots of amazing community organizations and grassroots organizations doing radical, amazing work to get people to care today, and their work is going to be increasingly important. And I think there's a role for technology if it's done thoughtfully. And I think there's a lot of room to start supporting some of these organizations who are really focused on access, because there's such inequitable access right now on abortion care, gender affirming care, contraceptive access, you name it.
I kind of want to talk a little bit more about these gaps you were talking, actually, the thing that you started out in saying, which was, we get the research and then, and then it takes years for it to come into practice. And not only does it take years, but sometimes actually the research never really makes it out sometimes. We see that sort of drop off in, venture capital. We obviously see that all the time. And I see how ARPA-H is trying to change that, right, through their model. But I'm curious about other ways outside of sort of this federal vehicle to bridge those gaps.
Like one interesting area I think that we haven't really hit on directly or not with enough emphasis is our really terrible record with childbirth in the U.S. And how that's impacting both communities, white or people of color that don't have money, and then certainly in communities of color where we live in a world where Serena Williams, of all people, did not get the care that she needed and almost had, a really bad outcome in childbirth. And there's so many areas. I mean, that one would be one that you would think would be critically available to new innovation. But there still isn't the kind of solutions we want for preeclampsia or hemorrhage or other areas that are really having, in all the parts of the heart with childbirth. And you're the expert in this, but we're looking with long priority list on how we can find solutions that not only can impact all women, but especially look at our Black and brown sisters that are really suffering the most in childbirth.
Well, thank you for that. I think, there are a variety of mechanisms I think we could be using. One is we're lowering the barrier to publication with more open access journals. We're also translating what's in the journals to the public sphere, so we're putting it into lay language so people can have access to that information. I think the advancing health literacy is going to help with that, so people are asking the questions of their providers. I think the multidisciplinary collaborations that Dr. Mazur was talking about are bringing it out of just one silo of a discipline so that you can have have wider fingers of how things are disciplined, are disseminated. And then we also have concepts that provide multidisciplinary teams that we deploy throughout the country to do precisely that. We have a program called Alliance for Innovation in Maternal Health. And that's an example, and we have other similar programs where we take the evidence-based information that's been carefully put together and we go to different hospitals and health clinics to make sure that people know about it. So I think, and we do that in partnership with community groups as well. So someone mentioned the really importance of community engagement and the research not being done in isolation, making sure that there's some collaboration and partnership as equals and not as just as subjects.
So we have a new administration that's coming in, and I am curious if there are areas of research you think that might take a hit during this time, or, I mean, and also I'm curious if is ARPA-H well set up enough that, I mean, do you have concerns about what will happen to your funding, for example?
So we're a bipartisan organization. We actually get our funding from Congress, and I can't comment too much on it, but I know that our Sprint for Women's Health, we have obligated the $113 million for the next 2 years. And to be frank, our mission is to accelerate better health outcomes for everyone. Everyone has a story, especially in women's health. You have a mother, you have a daughter, you have a sister, you have an aunt. And I think it really, no matter who you are in life, there's always going to be someone that's affected by that and wants to really accelerate better health outcomes in women. So I would take it upon other people, if you're interested in if you have a unique idea in women's health that you want to bring and kind of break down a barrier, come and work at our agency for 3 to 6 years. That's really how we come and bring the ideas into our agency. It's not top down, so no matter what, it's not our director telling us what to do. It's the program managers coming in to be able to bring those unique and creative ideas, be it in women's health. So I think for now, we're bipartisan. We have our obligation for our women's health, and we're really going to still fight for our cause.
Sorry, thank you. I'll reprise my first question that I didn't fully get out, which was, do we think that there might be areas of research that suffer in the next several years? Or are there enough funding mechanisms outside of federal funds that can sort of sustain women's health research broadly?
I think there also has to be a big push for public-private partnerships, especially within the government to industry. Something for us, we have these launchpad or later stage R&D efforts that we want to get out to market, and we can only take it so far. We're going to need the help from industry, the help from venture, to really look at these innovations where we can de-risk them enough that we can have that private sector step up to be able to take it to the next level. So I think that's a really important thing for us at ARPA-H and for our awardees to be able to keep these innovations going and make them successful long term.
So I think there's I know we're going to talk a little bit more about this, but venture capital will fund research, but you're looking at, like you're talking about with ARPA-H, you're looking at a 2-year to market. You're looking at a shorter period. You don't want to be in, it's a little more difficult. You don't want to be in for 10 years, on the research phase. But for instance, we're backing what we believe will be the first male daily contraceptive. So the first male birth control pill is now in research. And that is, we invest in that through our Women's Health Fund because we think it's also a women's health solution. But they're in research right now, going very well, proven, and this is all through venture capital dollars and a small grant, that they're able to stop fertilization, in sperm. And now what we're looking at is how long will it take to reverse it? Can you reverse it in 30 days or 90 days? So it really is getting, quite close and quite exciting, where men will be able to take their daily pill, and it's non-hormonal. That's been the holdup up until now, is men have a hard time dealing with the hormonal repercussion of birth control. True, that's true. So that's, so when you have something like that where you can see the huge market potential, you will definitely have ventures stepping up.
I'm curious also, a conversation I keep finding myself having, this is not unique to women's health, this is sort of a broader healthcare conversation, and things we already know. We know the healthcare system is fragmented, right? And it's in women's health in particular, it's interesting because like both of you, Tammy and Anna, are talking about the ways in which women's health is often sort of siloed, right? Either reproductive care, it's over here, abortion care, it's here, fertility, it's over there. It's not really in the mainstream setting. And I wonder about getting it into the mainstream setting and if there is a path for that. And if there is a path for that, everyone, please jump in all at once.
I don't see that in the next 4 years. And as unfortunate as that is, there's been so much work done to normalize, particularly abortion care, because it is, again, a very normal thing. 1 in 4 women will experience it in the US. So I think despite where we were, I think moving forward, the reality is like, no, it won't get integrated. It will increasingly become more isolated, but I think that doesn't mean people won't need it and that we disregard it as far as like an important healthcare, as important healthcare for people to access. And so I think really leaning on the expertise of people in the community who are making sure that access stays there is where we need to focus. And I think there's still an opportunity for lots of research to be done around these innovative models of healthcare delivery, because just like in the way that it's isolated in so many ways, funding is typically not dependent on the federal government, it's philanthropy. And so I think there's still a lot of room for us to see innovation in the abortion space in the next 4 years.
I'm sorry.
No, I was just going to say that, I mean, there are a number of areas that have enduring, that override any particular viewpoint, whether it's healthy aging, whether it's cancer prevention. You mentioned maternal mortality. I think like 5 years ago, we really weren't talking about maternal mortality or severe maternal morbidity in the way we are now. That is something that really probably impacts almost every family has a story in that regard. So definitely there will be challenges, but I think we're all here because we want to make sure that the next generation and our, the generation ahead of us and the generation behind us live the healthiest lives possible. And so we're gonna make sure we do whatever we need to do to make sure that happens.
I'll just add, I'm sorry. No, go ahead. I was just gonna add that to your question, I actually think that the mainstreaming of IVF in particular has happened and is happening now. Access to fertility treatments in IVF is one of the only bipartisan issues and an area where I think there is solid and growing consensus to both protect and expand access. And I think the culture, the shift in our ability to talk about it at home and at work, and then commitments from across the private sector as it pertains to employers and health plans, but also on national and international policy agendas is actually pretty exciting.
Mm-hmm. Did you want to?
Well, there's just a interesting dynamic about the mainstream is when we were looking at the mainstream, there was one standard of care, and it was for a white man. Mm. And so many of the things that have been a success for us is being able to say there's not one standard of care. The mainstream should not be the mainstream, in that same definition. We should be looking at how women's, across almost everything, heart health is the one that, so obvious, but so many things are different for women to have optimum care. And we need to make sure that that we don't try to accept that these things are simplified by not giving that really deep personalization for what women need in their care.
Yes, and and I will say also when I mean like the mainstreaming, I also just mean like I would like to, go to my primary care doctor and be able to get like the vast majority of my care as opposed to sort of being shuffled off to, various, it's not even a matter of just like being shuffled off to a specialist necessarily, right? Because now, we have these like various programs and it's, and that goes for like employee benefits too. It's not stitched together. Yeah. It's just not. And it's not necessarily easy for the patient in that way, right? And that's how you get these gaps. And so with that in mind, I'm curious about how particularly, well, Jenica, you've talked a little bit about this, about how, planning for marketability, right? Mm-hmm. And actually this is for everybody. As more and more research comes out, we may have a glut of research on women's health in the next 5 years, who's to say 10 years, right? And so I am curious if we should be putting more thought towards how that ultimately reaches women, like how those results reach women. Sometimes it happens in really obvious ways. A paper comes out, it says, we now know, I don't know, I make something up about heart health, and so that stuff gets adopted into guidelines, but that's not always how it happens, particularly if the investment is coming from VC and then it like becomes productized and it's not ubiquitous. And so, yes, I'm curious how all of you are thinking about this.
Well, I'll say I don't think at ARPA-H, we don't measure our success by getting a publication. We measure it by actually getting it to meet our mission to get the solution to the hands of all people. So for the Sprint for Women's Health, we try to set that up strategically in the terms of looking at across the technology readiness level to see areas where we could ideate to make something a reality into a prototype, as an example, or move it out into the market in 2 years. We have a really unique a network within ARPA-H called ARPANET-H. So it's a nationwide network that's helping us build kind of these communities and capabilities along any innovation we make at ARPA-H, but also piloting it with the Sprint for Women's Health to be able to see what are those barriers we need to break down for things to actually be successful into market. We've heard many things, regulatory, reimbursement, manufacturing, user experience, making something someone actually wants to use, not making shelfware. So we've built that into our sprint across the entire technology readiness level so we can shift those things a little bit farther to meet our mission, to get those innovations into the hands of people.
You talked about a lot of things, but I do think that along with innovation, we need to be thinking about innovation in education, innovation in, so for a lot of the conditions that affect women later in life, there's some common threads that are not that uncommon. So diabetes, hypertension, which are ultimately drivers of a lot of the severe maternal mortality, morbidity and mortality that we see. You talked about fragmentation. So investment in how we can ensure adequate training of our frontline providers and making sure that people are, that the people receiving the care know what good care is, as well as we are doing that in our public spaces, but we're also working very hard to train culturally humble, well-trained primary care OBGYNs who will be working with people. And as they need more specialized care, they're able to then do that in a very selective way. So I think we think about innovation as a new drug or product, but we also are looking at innovations in how we're training and educating our next generation as well.
To sort of thread this back to the topic of the conversation in partnership, there's been some really amazing discussion in other panels around the participation of end users, patients, community, however you want to describe them. And I think that holds true here in reproductive health or women's health. And I think it was the rare disease patient engagement panel that talked about this really well. But I think one of the key pieces for access and adoptability of an intervention is definitely making sure that the stakeholders in there are not tokenized, but are truly involved from the very beginning, because they're going to impact the kind of research questions you're asking, the kind of innovations you're making, and you're going to build trust along the way to make sure the dissemination and adoption is there. And so I think that's something that I hold very true to the way that I do my work, and I think it's something that you see more and more, and it sounds so great that you all are doing a lot of that in the way that you think about what success looks like. So I just think that is going to be a key component to anything that gets translated.
And not as an add-on, something
Yes.
really incorporated.
Yeah.
Yeah, absolutely.
So from when we're looking at going, taking these new innovations and processes, into the market, there's that really key component of getting the fuel, getting the money to do that in. And there's some good news and there's some bad news, I think, from the venture side. One is that the good news first, I created the first venture capital fund for women's health, and that was just in 2018. And since that time, there's been a 300% increase in money in venture capital being invested in women's health. So that's the good news. And myself alone, we've invested in 60 companies. 2 of those are already billion-dollar-plus companies.
Wow.
We're on our 3rd fund, and we also have 3 funds in active aging and longevity, so 6 altogether focused in this space. But even though it's increased 300%, the bad news is that is still 2% of all the venture capital in the US that goes into healthcare. 2% went into women's health. So it's still barely scratching the surface. But that's that critical piece, those young, especially those young companies that have innovation. Once they get their money from Jenica, they need to be able to have, they have to create, they have to, in some cases, manufacture, or they have to get out to the physicians, or, they have to get out directly to the consumers. It's very costly. And there's a lot of challenges around that, and a lot of those ecosystems aren't set up yet. So it's really critical that we continue to build that out. And I'll just tell you that in our funds, I have 2,000 women that have written out $25,000 and $10,000 and $50,000 checks into my venture funds, so that money goes into women's health companies. So it's taking community and it's saying, some doors may be shutting to us, but if we want to put our investments, we can do that and back those kinds of companies. There's 150 other companies that I consider right now venture ready and ready to go, and there's just not the money for them. So, and it's really interesting, kinds of things. We've got a solution for osteopenia now that will maintain your bone, that's not a pharmacological solution, that just went through FDA, the OsteoBoost, using the technology that the astronauts had to create so they didn't lose bone mass in space. And there's hundreds of those things that will impact our lives. And so there is hope, even though it is just 2%.
Can I just say, offer something? I just so agree with Trish, everything you've said, and I do think, to your point on education, I think that the private sector and these startups can have a really big impact on communicating and storytelling through the brands that they build, through the marketing that they invest. I think there's a lot of consumer education that can benefit everybody broadly by these companies coming up, some of them failing, but still doing that work and contributing. But the ones that are really successful also have, I think, a really big role in shaping the market and educating consumers. So great work.
I have such limited time left, but I'm going to try and squeeze in a question about, I'm wondering if through all of this research and this investment capital and, developing healthcare outside of, the traditional healthcare market is, one of the things we talk about in healthcare is like the incentives in healthcare are not great, right? Fee-for-service doesn't always get us the care that will make us healthiest. And I do wonder if there is an opportunity here with this research to shift how we think about care models, create better incentives.
I think that while as excited as I am and we are about access to IVF, I do think that there is a significant risk that women are shuttled into IVF sooner and faster than they need to be, and I think those incentives need to be very clearly mitigated as this industry grows and evolves. We shouldn't be pushing women into surgery and drugs unnecessarily. I think fertility is a really personalized, to your point, area of healthcare, and one cycle and one size doesn't fit all. So we really need to think comprehensively and holistically as this category is being formed about personalizing care for every woman and every member so that they can have access to IVF if needed, but also really potentially help them achieve a healthy pregnancy and a healthy birth without the physical and the emotional and the mental burden of having to go through IVF if it's not necessary. And I think it's really important to think about almost over-commercialization of that treatment as it does become more popular.
No one else. Come on, someone.
It's a huge topic
I
to talk
know
about.
it is, I know. In 3 minutes, give us high-level thoughts.
Well, I guess, value-based care is an attempt to approach what you're talking about. I think the work is slow, but the attempt is to look at a holistic view of what it takes to care for somebody for an episode of a problem. It's challenging. Yeah, but there is work that's going on. I mean, I think there is some work that tries to look at innovative solutions, and I think the fact that more and more organizations are recognizing that being part of a clinical trial or a way to vet new technology or new drugs or instruments, most large systems have a mechanism for that, whereas 5 years ago they perhaps did not. So I think it is happening, but it's not probably as quickly as we would want it to.
Totally. Thank you for taking that bullet. Well, thank you so much to my panelists. This has been a good conversation.
Thank
Thank
you.
you. Thank you.
Thank you for attending this session. Please join us for our closing plenary happening in the ballroom at 4 p.m.